That's it, man. Hi, what's going on, guys? Welcome back. I'm Dr. Robert Watkins IV with my friend Dr. Casey Batten. He's a team physician for the LA Rams. He's part of Curl and Job. Most of the time he's up in Westlake Village, and on Thursdays he's down here in LA at Curl and Job Orthopedic Clinic right down the road. And I appreciate you sticking around today and joining us.
Yeah, thanks for having me.
Yeah, thanks for coming. So I invited Casey because we take care of the Rams together, and we talk a lot about doing injections on athletes and on everybody else and what works, what doesn't work. That's kind of what we talk about on the sideline for the most part, is random medical discussions. But I invited Casey because he has so much experience. You know, athletes are always on the forefront of treatments because they're under a time crunch and they got to get back to their job and as quickly as possible. And so in some ways they learn about things before the rest of us, but they're also susceptible to going all over the world and getting new treatments and people trying stuff on them because they're really under time crunch and they got to get back to their jobs. So Casey's got a lot of experience with seeing what athletes have done all over the world and what works and what doesn't work. And he does biologic injections himself. And as we're exploring this topic, you know, you realize stem cells is a big topic. And it's not just about taking some stem cells and injecting it into somebody. And in fact, the more I look into it, investigate it, and the more I talk to people who are doing it and read all the papers and everything is, I've shifted my mindset to where it's not necessarily what cells are you injecting into somebody, it's whatever you inject, what is it eliciting in the normal person's body to cause the reaction you want. And that's where it comes down to injecting PRP and regenikine and all these other products. They have a very similar effect as stem cells because they stimulate a reaction in the human body to get what you want, the desired effect, to get some form of healing or anti-inflammatory. And so Casey's got a lot of experience with different body parts. He doesn't do a lot of spine. He generally leaves that to us. But every joint in the body, which is what most athletes hurt. And obviously he treats everybody. He takes care of the high-profile athletes, but he also takes care of normal people, weekend warriors, and everything else. And so is there anything else introducing yourself? Actually, you took care of the Cal football team.
Yeah, I was a head team physician for the California Golden Bears, all 30 sports. So I was there. I was the head team physician for about 7, there for about a total of 10 years. So when the Rams moved from St. Louis to Los Angeles, made the difficult decision to head south, but it's been great so far. So.
Yeah, nice. Yeah. So you obviously have a lot of experience of every college sport and every injury they get and all the overuse injuries. That's great. So let's start out. We'll start out with the stem cells. And so going back, and we've got a wide audience. We got doctors, we got physical therapists, athletic trainers, chiropractors, and friends of mine and family and people just in pain and looking for some answers. And so a quick review of just stem cells. There's bone marrow aspirate cells that you get from the bone marrow, which are bone-derived. There's adipose, which are fat-derived, which typically you get from liposuction type of procedures. And then there's umbilical cord cells, which basically come in a frozen packet from umbilical cord, and you can it's an allograft, and you can keep it in a freezer in your office and inject that. And then there's also amniotic fluid, which potentially has some stem cells in it, as well as all the other proteins and factors that can stimulate this response in the body. And so what's your main experience with stem cells so far?
Yeah, like you said, it's a huge, tremendous wide field, right? And when people say stem cells, I think when I see a lot of patients and they say, well, I had a stem cell injection, half the time I ask them, what stem cells do you have? Yeah. And they can't even really tell me what it is. Yeah. And I think that's part of the problem with this is really the education of the public of what stem cells are and what they aren't, and where they're coming from. And when I see a patient and I'm going through all their options, I really like to discuss, like you said, is first of all, what am I trying to heal? What are we trying to get better? Yeah. And then you kind of go pick, the stem cell, the PRP or what have you, and we'll talk about PRP later. But for stem cells, there's a lot of people in our group who do a lot of the bone marrow aspirate concentration, the BMAC, if you will. Yeah. I do not do a lot of BMAC, not that I don't think it works. It's just part of my practice and the invasiveness part of it and the time consumption.
And so what it takes to get the BMAC is bone marrow aspirate. Right. You got to stick a needle into someone's hip, typically, their iliac crest, and suck blood out, spin it down, and get all the bone marrow, the thick cells out of it, which has bone marrow. Yeah. But also, what are some of the downsides about a bone marrow aspirate?
Well, believe it or not, I mean, it sounds pretty kind of medieval to put a big needle and drill into somebody's pelvis and take out bone marrow. If it's done right, it's not actually as painful as you think.
Yeah.
Some people will have a little soreness after the fact, but it sounds a little worse than it really is in reality, but it is invasive,
Yeah.
right? And some people, there's a lot of anxiety about it and what have you, but for the most part, it's a pretty low risk procedure.
What about the quality of, what are you getting in that aspirate? Is it a lot of stem cells? Is it a lot of the proteins and cytokines
Right.
too?
So there's a lot of factors. Good question. And so you do take out bone marrow, and there's a lot of literature out there that looks at, you know, how many cells are in there that are actually viable, that are able to do its job.
Yeah.
And that there's a lot of things. It depends on the site of where you take that from. It depends on the age of the patient. If you're older, you may get bone marrow, and the amount of cells, the quality of the cells and the amount of cells are not going to be as good as if you took it from a healthy 18-year-old.
Yeah.
So all that's kind of things to consider. And then also when you get a bone marrow aspirate concentrate, you also are getting other proteins and, like you said, factors that you also get in PRP.
Yeah.
So when you're getting sort of a BMAC injection, it's not just purely, you know, a purified stem cell preparation.
You think there's any ideal conditions now for the BMAC bone marrow aspirate?
So again, for someone myself, a clinician who doesn't do a lot, but
Yeah.
we have people in our group who do a lot. If you look at some of the animal studies and the literature out there, there are some of the orthopedic surgeons and people who are using them to augment certain surgeries they do, like rotator cuff repairs.
Yeah.
There's some animal data and human data that looks at BMAC and putting that when you have a rotator cuff repair, that there's been several studies that looked at not necessarily healing, but the rates of re-tear. So people who compared to people who were treated without,
Yeah.
you know, BMAC versus who do, that their rupture rate is significantly less.
Right.
There's been a few studies that have shown that. And then some of the bone healing uses. So certain people who have big cartilage defects in the knee, where they're getting, you know, bone plugs or they're getting grafts. There's some good data that helps those heal faster.
Yeah.
And that's based on MRI data and actually second looks where they've gone in with a scope into a joint, let's say a knee, what have you, and they said, yeah, this looks, you know, healed faster and more completely than people who were not treated with the BMAC.
And some of those cartilage defects that the stem cells get injected into, I know some of the MRIs look okay, but there is some question as to what's the quality of the cartilage, isn't it? Because they call it hyaline-like cartilage.
Right.
It's not exactly hyaline perfect cartilage. It's like it, kind of scar tissue cartilage, but maybe still is functional.
Yeah, right. And if you look at I would say old techniques that are still used, microfracture. Some of you might have heard of that, where you have a cartilage defect, and depending on the size, you go in and you basically drill holes or poke holes to get the area to bleed, and it scars in, and you get hyaline-like cartilage. So it's not going to be normal cartilage, but there at least is some protective tissue there to bear load and protect the underlying bone. But kind of jumping to the chase here, or to the punchline, I think with stem cells, I think the biggest misconception out there, and probably if anything, the biggest take-home point to me is, I have a lot of patients coming to me saying they saw another provider, and you know they have bad arthritis typically, and they say, well, we're gonna heal that with my stem cells.
Right.
And I think the biggest thing to understand is there is no good data that shows that you can actually reverse or heal cartilage.
Right.
Or at least to make it back to normal.
Right.
Or to completely regrow another tendon or regrow another ligament.
Yeah.
You know, there are parts of medicine out there with stem cells, and you look at kind of in cardiac and other things, and, you know, nerves and what have you, where you can actually engineer things, but we haven't really seen that in the orthopedic world.
Yeah, one of the big things with joints is the mechanical environment. Once that starts to deteriorate and you get instability of the joint, well, it doesn't matter what you inject in there, it's still falling apart. And so Mike Banfi, another doctor for the Rams that we talk to a lot, says he does osteotomies where he corrects the alignment of the bone and then does some BMAC stem cells, because he's corrected some of the mechanical deformity in addition to the bone marrow, which certainly has some possibility. Have you seen any problems, disasters, complications with BMAC? Any, you know, I think we mentioned over the phone about the potential urban myth about muscle growing in somebody's knee joint from a BMAC injection, which we had both heard, but we couldn't remember where we heard it from.
Yeah, I was trying to look it up, and I think some of that might be a little bit of an urban myth. Now, there has been some instances where they've taken stem cells, and I don't recall if it was from bone marrow or not, but they were, and we can talk about this later when we talk about safety, but they were culturing them in a dish.
Yeah.
And they said there were some, they grew sort of some abnormal tissue,
Right.
kind of out in vitro, outside the body.
So we can mention that now. Someone
Yeah,
asked us a
yeah.
question about tumor genicity and markers for, is this thing becoming a cancer? If you inject stem cells, does it become a cancer? And can you mark for that to know, to screen out those cells or not? And I might have run across the same study that basically said, if the processing is short term, like 3 to 6 weeks, they did not see any tumor genicity in cancer cells. But if it was more like 3 to 6 months, they did start to see some. So how long you process the cells and let them grow outside of the human body may determine how likely they are to become cancerous.
Yeah, that's part of it. So there's
Yeah.
multiple things. One is sort of what your stem cell source is, right?
Yeah.
So when we're talking in the orthopedic world, and you're talking about bone marrow, not to get overly technical, but you're talking about MSC or mesenchymal stem cells.
Yeah.
And so these are cells that are further down the line of what we call differentiation. So they're able to come bone, tendon and ligament type tissue,
Yeah.
but you're right, adipose and fat,
Yeah.
but they're kind of limited to those lineages.
Yeah.
The further you go back,
Yeah.
the more potent they are.
Yeah.
So MSC cells are multipotent.
Right.
But if you go back to the pluripotent, totipotent, all these things,
Yeah, more like
the
embryonic cells.
The more active they are,
Yeah.
right? The more
Yeah.
primitive, if you will, the higher risk of
Yeah.
theoretical risk of tumor genicity.
Right.
The other part, like
Was just one of the reasons why
Right.
people have shied away from embryonic stem cells. Not
Right.
only the political controversy,
yeah, right.
but it's also, these things can be really powerful and they may cause significant problems
Right.
that we don't know about.
Yeah, so you're right. And then how much did you process it? How much did you manipulate the tissue and try to stimulate these cells to divide?
Yeah.
So I think there are some definite risks with that we don't know. And then in terms of the MSC cells that we're pretty much talking about tonight,
Yeah.
we don't know of any significant increased risk of cancer with these types of injections. Now, the follow-up time period has been rather short in
Yeah.
a lot of these studies, 1 year, 2 years. Some people are saying we need to go out to about 5 years to really see if we're seeing any kind of changes.
Yeah.
But of all the cancers that have been seen in patients who have had these injections,
Yeah.
I think one was prostate cancer, the other was something else that was determined not to be
Yeah.
related to the injection.
Right, it's probably going to happen anyway.
Right,
And maybe
right.
stimulating inflammatory reaction in the body could have triggered it to happen a little bit
Yeah.
sooner, but that's kind of a stretch. Let's pivot to what you do. So you do amniotic fluid injections?
Yeah, so I do a thing called amnion or amniotic fluid injection,
Yeah.
which I also see a lot of patients come in and say that they've had amniotic stem cells. And there are, at least in the past, there were parts of, so what is the amnion? Amnion is that sac that surrounds the baby.
Yeah.
And within that sac is the fluid, and that's the fluid, right, the baby breathes. But within that fluid, and actually within the lining, the actual amnion itself, is a very concentrated milieu of growth factors.
Yeah.
And so the one that you can use now is purely just unprocessed, flash frozen, cryopreserved, we call it.
Let me ask you a technical
Fluid.
question
Yeah.
because it's been a while since I
Yeah.
delivered a baby.
Yeah, right.
Is it the afterbirth? Where do you get it from? Or do you aspirate it?
So it's
Yeah.
from, right, so when
You
they get the
aspirate it
amniotic
before the baby's
fluid,
born?
Yeah, and they take it out from the amnion that's left. Yeah.
Before the
Yeah,
gotcha.
yeah, from
Okay.
right.
All right, good. Refresher. All
Yeah,
right.
so the placenta there's parts of it, there's placenta, there's
Right,
placenta
right.
side, baby side.
Yeah.
But
It
it's,
needs to say the baby's not harmed.
Yeah, yeah,
The
there's-
you're not stealing from the baby.
yeah, these are all kind of planned C-sections, everything is screened.
Right.
But I think of the amniotic fluid as sort of like what we'll talk about soon as a PRP, or platelet-rich plasma, but this is not really a stem cell injection.
Right.
There are cells in there that have stem cell markers, so they can potentially behave or have some properties like stem cells. But I'm very clear to people this is not a stem cell injection, but what it is a very biologically active injection with a large concentration of growth factors that you see in platelets, but in a higher concentration. And then again, the pros of this is you don't have to draw blood, process, what have you. Now, it is not your own tissue. Some
Right.
people have issues with that, but there are some benefits that I've seen with the amniotic injections.
And that's an interesting one because I've talked to a couple of people who do the umbilical cord injection, stem cell injection. Now they can't call it stem cells. Let's be clear. And we say stem cells, but let's be clear. FDA rules. Well, I don't even exactly know the FDA rules, but basically, if you're going to call it a stem cell, it can only be a stem cell that you're injecting. If there's anything else in it, you can't call it a stem cell. That's correct, right?
Yeah, right. And you can't in the United States, you
Yeah.
cannot manipulate everything, and it has to be sort of like use. So you're kind of
Right,
taking a
like
stem,
use. Yeah, that's an interesting phrase.
Yeah, I can't remember the exact.
Right.
In those rules.
So with that, so some of the people I talk to who do umbilical cord stem cell injections, which is basically comes in a frozen packet, the umbilical cord, that's cut up and frozen, which I think has more stem cells in it than the amniotic fluid because it's more cell based. It's got more mass to it. But they say that it's really not necessarily the umbilical cord stem cells that do the work. It's not like those stem cells, it's not like you inject it in your knee. Those umbilical cord stem cells become cartilage in your knee and lay down and become the cartilage, which is what most people think stem cells are doing, that they're giving you the cells. Most of those practitioners think that those umbilical cord stem cells stimulate your body to trigger nascent stem cells, stem cells that are dormant, that are just laying there waiting to be activated. And the umbilical cord stimulate them to become the cells you want them to be and to do the process. And so it's interesting that you're doing this amniotic fluid, which is more the juice and the cytokines and the proteins to stimulate everything, which may be just as effective as the umbilical cord stem cells because the people who do the umbilical cord claim that's what it's doing anyway, is the juice. Does that kind of make sense?
Yeah, for the most part. I mean, there's a little bit different pathways, and it's kind of hard to just talk about it. But yeah, the end pathway is sort of the same. It's the same concept, but you hit the nail on the head. Is you listen to these kind of world experts on stem cells, and I was telling you the acronym of MSC for mesenchymal stem cell. They call it now. They say, well, we should probably call it. It's more appropriate to say a medical signaling cell because all it is potentially causing your body, stimulating your body to take a reaction that it otherwise wouldn't have taken. And like you're exactly right. It's not actually taking these cells and they're the primary cell dividing and growing your new tissue.
Right.
100%.
So it's pretty interesting when you think about, marketing on the internet and, hey, come cure your back pain, cure your arthritis, get some stem cell injections, when in really it's like, come get some young, more afterbirth tissue injected in you, hoping it's going to stimulate your body to work better. It's kind of a stretch, isn't it?
A little bit.
I mean, just conceptually.
Yeah.
So which is different, and that's a real breakthrough for me that I'm glad we started doing these because it's not the cells. I was fixated on the cells. What do you inject in there? Where are they becoming? Can you mark them? Can you see what they're becoming? It's like, no, it's stimulating this reaction in your body, and then you want it to do the right job. And so it's certainly got potential. I mean, what affects, and let me ask you one other question about this amniotic fluid. So one of the risks with the umbilical cord is what we saw down in Long Beach. I think I mentioned on the last one, a patient of mine came in, almost died from sepsis from an umbilical cord stem cell injection in his spine. And from a contaminated batch. This is down in Long Beach. They shut down a lab, Livion. Knock on wood. I think I'm saying the right name. I'm not, but it shut in. There's like 10 cases of sepsis in the LA Times, and part of that is, the tissue has to be processed to kill any potential infection, but you can't kill the viability of the cells. They still got to be able to do something. So I guess how do you know the company you're getting them from? And what's the quality?
Yeah. I don't know if I have a great answer for that. I mean, from the amniotic fluid, I can tell you there's no processing. In fact, they used to, you can't process it. Part of the FDA rules, you can't process it. And it's not your own tissue. So from an infectivity, I guess, can you get diseases? The answer is yes. It's sort of like a blood transfusion, but it is fetal-sided type material. The mother is screened for all the communicable diseases. It's actually held for several weeks, actually a few months, and then they retest it.
Yeah.
And then it's clear. So I don't know. And actually, some of this stuff has been used for other parts of surgery. Yeah. Amniotic fluid is probably the most anti-scar formation biologic we have. Anti-scarring. Right. So there's people who put it around nerve surgery, rotator cuff, where they don't want scarring. It's extremely powerful for that and wound healing.
Yeah, I've heard that.
And there's different forms of that. It's been used for many, many years. And to our knowledge and the company's knowledge, there is no documented, infection. But, anytime you put a needle through the skin, sure, you can get infected. But
right, and that's an excellent point that blood transfusions, probably the same testing. You test for HIV and hepatitis, and we take blood transfusion all the time, probably processed pretty similarly.
Yeah.
that in many ways, how would you get an infection from a blood transfusion? Well, it's probably how was it handled and who stuck the needle in and how was it delivered to you is more likely the source of the infection than potentially the product.
Yep.
And that's a good point. So that does sound relatively safe. So let's move on to PRP, because I know that's what you have a lot of experience with. And again, the same thing that I was stuck on with platelets. I was thinking, why would you need to inject platelets into a healing tissue? That assumes your body doesn't have the platelets it needs to heal itself. That was my thinking 3 months ago, realizing now it's not necessarily the platelets, it's what are the platelets doing to your own body.
Right, exactly.
Yeah.
I mean, if you look at the phases of healing, bone, tissue, like soft tissue, like tendon or ligament, there's sort of these 3 phases, right? So there's this initial inflammatory phase, and then a couple, days to weeks later, then you get this proliferative proliferative phase, and then you kind of get this remodeling maturation phase that can go out for months. And each of these phases is regulated by its own little set of chemicals, right? And cells. And so, depending what the injury is, how old the injury is, where it's at, you can use things like PRP to help, I would say, augment your healing response.
Yeah.
And so, what PRP is, or platelet-rich plasma, a lot of people have been hearing about this for years. The simplest definition of that is you draw blood, you put it in a centrifuge, you spin it down, you take a certain portion off the top that has concentrated platelets. And within platelets are these little granules full of these growth factors that can help augment and assist healing. To have more complete healing and faster healing.
Right.
But the problem is that just like the stem cells, and especially PRP, there is a wide range of PRP out there.
Right.
And it's not created equal. And the types of PRP you use for a certain type of, certain condition also vary. And so when you look at the research, and the difficulty in coming to conclusions is, you look at one study that looked at, let's say, knee arthritis, well, they might have used a completely different type of PRP than the other study. And so we're getting better at learning what conditions respond best to this certain type of PRP.
Yeah. So what do you use right now? What have you found is the most effective for PRP?
Yeah.
What conditions?
Yeah. So I would say, the vast majority of PRP I use is for mild to moderate arthritis. Pretty much in any joint, shoulder, elbow, knee, ankle, foot. I mean, really, pretty much any arthritic joint you can use PRP in.
So basically, now will you do that instead of a cortisone shot, or will you try the cortisone if it doesn't work, then do the PRP, or how do you
typically, for me, some of it's patient preference. Now, if a patient is not averse to a cortisone injection, I'm still often starting with cortisone. I may start also with some of the lubrication, hyaluronic acid, lots of different names out there. Even though there's a lot of literature and people say that doesn't work, I do think it works. But usually I add PRP in as sort of that second or third stage of treatment if they've sort of failed the others.
Does insurance cover PRP?
As of right now, no.
Typically not.
Yeah,
they will cover hyaluronic acid for 2 injections a year.
Yeah, they get it. Usually it depends on what you're doing, but every 6 months, it just depends on what you're injecting and what your insurance is. Some of the insurances have backed off on covering that. Yeah. But the costs have come down. It is more reasonable.
Right. And the PRP, do you think the PRP is an anti-inflammatory or regenerative?
I think it's purely symptomatic. To go back to my point, I don't think of PRP, and I'm very clear to people that this is not going to reverse any damage in your joint. This is for pain. This is to decrease pain and potentially increase function, because that's what you're looking at. When you look at arthritis research, you're asking patients, how do you feel and how happy are you with your function? It's not really regenerative. There is some evidence with BMAC and PRP potentially that you might slow progression, maybe, of kind of cartilage breakdown. It may stabilize cartilage to some degree. More research is needed, but for me, it's for pain.
And for mild to moderate arthritis, otherwise known as aging, how much do you think people should just come to terms with they're getting older, they're aging, they should slow down their activity and don't push their joints as much, versus getting an injection, feel better for 3 months so they can keep getting out there and kicking butt every day?
Yeah, it's a good question, because like you said, in the professional athlete, you're doing these things to get people back to very high level sport. And the real reality is most of this time is to get people back to to their normal daily activities,
Right.
to be able to do laundry, you know, do the
Right.
dishes, go shopping, get to school, get to work.
Those are pretty reasonable.
Yeah, they're reasonable.
How
right?
much do you see? How much do you see unreasonable? How many patients do you get a week that come in and you go?
I don't know how
what,
many, but
you're just delusional.
Yeah, I mean, I spend a lot of time. I'll tell you, I spend a lot of time talking. I have a lot of people come into my office with, let's say, an end-stage arthritic knee, and they could even be relatively younger, even in their 40s, 50s, 60s, you know. Yeah. And they come in and say, you know, they're dead set, I want PRP.
Yeah.
You know, it's going to fix me. And, you know, at the end of the day, PRP, we talked about safety with stem cells. PRP really doesn't have any of those risks that stem cells have, and so we know it's very, very safe. But, you know, it costs people's hard-earned money. Yeah. And it's not going to work for everybody. And if you have a real, let's say, an end-stage arthritic knee, you know, if someone really says, hey, I want to take my money and I want to do it, is it going to hurt me? The answer is no. Yeah. Could it help me? Well, it's kind of like that Dumb and Dumber quote, you know. Yeah. So you're saying there's a chance, exactly. Right? Yeah,
exactly.
sure.
One in a million.
Yeah. So
right.
So there, you know, maybe it'll help you. And
right.
So if someone really wants to do it, sure, sometimes they'll talk me into doing that. But I do,
right.
like to answer your question, I do spend a fair amount of time talking people out of it because I just don't think they're good candidates.
Yeah. And in those regards, it's one thing if somebody has cash and they're paying cash, they can afford it. Hey, you want to try it? Sure. And if you want to get one every 3 months, and even with the 30% placebo effect, remember that 30% of injection, people are going to feel better 30% just from the placebo. Well, right. Is it worth paying $1,000 every 3 months to feel better for 3 months? It may be. But let me ask you this. From a societal perspective, and one is an insurance company, we all pool our money together for the insurance. Should we all pay for that person to get a 30% placebo effect for 3 months?
Yeah, that's you put me on the spot. I mean, it's hard to say, right? I mean,
that's a yes or no.
Yeah, no, I mean, probably not. But I mean, you know, I would say though, if you look at some of the, you know, we look at studies, level 1 being kind of the best down, you know, into the lower levels. There are some level 1 studies out there for mild to moderate arthritis. That PRP and BMAC and these things is effective. The other thing I talk to my patients is, you know, we have data, you know, at Curl and Job, and we like to do things based on data, not just because. Right. And we have, you know, hundreds if not thousands of patients that we've tracked their response to these injections. Yeah. And it's pretty interesting. There's also national repositories of data. Yeah. And ours perfectly match kind of their pain reduction curves and their function improvement curves. Mm-hmm. And so for us, kind of my spiel for someone with mild to moderate arthritis, if your average pain level is a 4 or 5 out of 10, we can get you down to about a 2. Yeah. And we might get you better for 6 to 12 months. Yeah. So, you know, you could say it's
pretty good.
Right, a 50% pain reduction, but that's a 4 from a 2. Right. I'm not taking you from an 8 to a 4 or a 10 to a 5. Yeah, right. It's a 4 to a 2.
That's a good point. Right. Because 2 points in a 10-point scale is questionably of clinical significance when we do our research studies. Right. But for the person, would you take a 4 to a 2? Yeah. Right. Yeah. You know, who wouldn't? Yeah. And obviously, I'm asking you that question where you could easily turn it around to me. I do epidural injections. Well, we get asked that question all the time. Is it really worth it? Insurance companies are trying to not pay for epidurals all the time because they're saying, where's the data that it's really worth doing? But I have patients all the time. Patients come to me every 3 months and beg me for an epidural because it helps them. Gets them by for 2 more months where they can walk and talk and enjoy their life better. And I think you're right. You get about a 50% reduction, and that's huge for the individual person.
Yeah. No, I agree.
What about Regenokine? You got any experience with that? You got any experience with any athletes going over to Germany, getting orthokine, getting any stuff and coming back? You think it works? Think it's
so I mean, again, it's all you know. The Regenokine, orthokine. You know, there's one of them that was developed in Germany and is done in Europe, and then there's a version of it that's done in the United States. Because here again, we're bound by certain FDA rules on how you manipulate tissue and. I definitely have had athletes that have, you know, again, most of the time this is for degenerative joint conditions, arthritis. I think the results are all over the board. I've had some patients that come back and they swear by this and they go every off season and they go to Germany and they spend their several days, they go on vacation and get their injections and they come back and they feel great for the season. Yeah. I've had several of athletes that have done that for years. Yeah. And these are high level, you know, multi-year, you know, NFL vets. And they've come back and we've done PRP or amnion injections and they say, oh, this is 1,000 times better than what I had in Europe. So again, these are just case reports. Yeah. I wouldn't say I have tons of data on it, but it's a process. Yeah. You know, there's a cost, there's a time, you know,
What do you think of the general idea? I've got friends of mine and even patients who say, well, the FDA holds everything down in America. Nothing, we can't develop anything in America because the FDA, you go to Europe, they got all this great stuff, and they're doing so many great things. Why isn't it here in America yet?
Yeah, I mean, I think the answer is probably, for the truth, I don't know what you want to say, it's somewhere in between, right?
Yeah.
The answer is they are more lax, and so you see a lot of things done in Europe and other countries that wouldn't fly here, and really it's safety standpoint. It's how much safety you have to, you have to prove how safe this is and how much leeway they give you in conducting these trials. And so, I think it's better to be more towards us, but there's some things where
we let them experiment on the Europeans, and then we bring it over here,
and then
we use it.
But this stuff has been done for years. I think it's safe. The question is it any better than what we're doing? I don't think there's any hard data. Again.
And then A2M is another one that's out that is basically a inhibitor of breakdown tissue, so maybe it allows some regeneration or anti-inflammatory. And have you seen any experience with A2M being used?
Personally, I actually had a couple of patients who've had it in their spine. I haven't had anybody really. I've had a couple people ask about it for joints. But I don't really have much experience for it. But A2M, stands for alpha-2 macroglobulin. Like you said, it inhibits these proteins that break down things that make cartilage, and so it's potentially supposed to, slow breakdown of cartilage and other tissues. But I personally don't have a lot of experience.
So it sounds like those basic things that are being used now, A2M, Regenikine, PRP, and even the amniotic fluid are stimulating this reaction in the body, and then they all are probably working similarly, but it's such a fascinating process because the amount of proteins and cells in the body, the growth factors that stimulate angiogenesis, blood vessels to come, healing tissues to come, the scaffolding to come. There's so many factors that what are you injecting and which one is it affecting? Is it affecting 1 or 5 or 10? It's so multi-layered and multifactorial that's why you're going to see 20 different products out on the market. And I think one of our purposes really, because Casey and I both see that people are just vulnerable to, everybody's in pain, everybody's getting older, everybody's tired, everybody wants to feel like they did when they were 25. And so getting these injections, these different products to stimulate your body to feel better, we all want it. And they all kind of are on this spectrum of, they've all got some utility as long as they're safe. Just part of it is just make sure you're not overpaying for something that is being overpromised when we don't really know necessarily what it's going to do.
Yeah, I mean, you hit the nail on the head. I mean, that's kind of one of the most exciting parts for me being here today. Was kind of early on is there are people out there who are misrepresenting of what this is. And to the degree that it actually may help you. And so, like you said, there's people that are desperate for just anything, and I totally get it. And I think there's a role for all of this. But we all work hard to earn our money, and before you spend potentially thousands, tens of thousands of dollars on some of these things, I would be very careful with it because a lot of the stuff that I do actually is probably some of the cheapest things you can do.
PRP is pretty cheap. You can get it from a blood draw, spin it down, inject it back in.
The costs are variable, but they're all usually in the upper hundreds to the highest I've heard is maybe 1,600 in the area. And again, not all
PRP.
And you got to be careful too. Not all PRP, and this is one point I should have made earlier, is not all PRP is created equal. And so there are different systems and different processes. Is the person injecting it with guidance? Are they using ultrasound to guide this? Are they using fluoro to guide this? Because these are expensive things. And if they're telling you they're going to inject it in, your tendon or your joint.
Bend over. We got it.
And you have no guidance. You're not 100% sure where that's really going.
You typically use ultrasound?
I use ultrasound to guide everything,
which is pretty, in the office you can, gotcha. I'm going to pivot one more thing because there's another topic that I'm interested in, especially in LA, is the whole systemic rejuvenation process of HGH, human growth hormone, a little bit of testosterone, a little bit of thyroid, these different things that are being offered, and to make people feel more alive and feel better. And I see patients all the time who they usually are embarrassed to tell me, and it's not until like I'm about to do surgery on them or I'm about to stick a needle, I'm doing epidural, they go, oh, by the way, I've been taking HGH for 5 years. Is that going to make a difference? And and it's fascinating because we don't really know what are the long-term effects. There's a lot of people who take them and think they have no side effect. And I know a lot of doctors who tell patients and tell their friends and relatives it's fine to take. For me, one of the questions is, what's the end point? Like, okay, I'm 47 now, and yeah, I'm more tired in the last 5 years. Well, if I'm going to start taking it, when am I going to stop? You know, when is it going to be okay to feel 20 years older, you know, than you want to feel? And so, what do you have any experience? And the athletes obviously is not allowed in the NFL or the MLB or you know, Olympics. But do you have experience, I guess? What's your experience with HGH and testosterone?
Yeah, obviously, you know, there are doctors who manage these things,
right,
and prescribe these things. And you know, if you get if we check our levels, we're all going to have, you know, testosterone levels and HGH levels, you know,
that are dropping.
Yeah, dropping, or they
right.
look at these ranges and they range. You know, some of these ranges, depending on what lab, are you know, they're within 100. It's huge, right?
Yeah.
So someone may get, you know, what's your T?
Yeah.
What's my testosterone level? And
Right.
they might be 300 and the limit is 1500.
Right.
But even though it's totally normal,
Yeah.
you know, there are people who say, well, what if yours is 600, 700, 800?
Right.
And we find out with a lot
Your
of
poor wife.
yeah, right. We find out though is that these normals are overpopulation. It's like
Right.
vitamin D.
Right.
What's an optimal vitamin D? We used to think you have to, you know, more is better. In
Right.
fact, now it's coming full circle. Actually, more can be harmful.
Really?
With vitamin, we don't know what happens to the kidneys and other things, and
Yeah.
so, you know, is a little bit more better. We don't know.
Yeah.
And so, you know, HGH. Originally, we were talking earlier before the podcast, this presentation here, that, you know, is there a role for rehab, but maybe not for performance enhancing? And
Yeah.
you know, there's
Right.
people who swear by it, but
Well, that's one of the interesting
Yeah.
questions is if you have an injury and you take some HGH to rehab that injury
Yeah.
and then stop it once you're better, and it shortens the time of your rehab by 25, 30%, but then you get off it. The versus are you taking it for a lifestyle? You know,
Yeah.
and I think that's a good distinction that, you know, sounds reasonable. The hard question is who's going to get off it once you,
Yeah.
you know, like I said, when are you going
yeah,
to stop
you said if you feel better, are you going to stop it? And like you're
Yeah.
right. I mean, we don't really know. You know, I think our bodies are pretty smart.
Yeah,
And if my
right.
level is still within normal, I
Yeah.
tend to trust my body, and so, you know, make no mistake, I don't advocate for any of these things.
Yeah.
Unless there's a real underlying medical condition or real true deficiency.
Yeah.
You know, are they safe? It's hard to say. The problem is what else are you taking? And a lot of these things, you know, there's these over-the-counter supplements. That's a
Yeah.
whole other subject
Oh,
that
right.
are just, you know, they say it's HGH or it's going to boost your testosterone or it's going
Right.
to convert X, Y, and Z to testosterone
Yeah.
and DHEA and all this other stuff. But
Yeah.
this stuff is not regulated by the government.
Right.
You have no idea what you're getting in that bottle. And
Right.
so if you're participating in any sport or work that, you know, drug
Yeah.
you have no idea. I mean, it's
Right.
happened. It's happened. People pop for things they had no idea they were taking, and they're held responsible.
Right. And to that degree, like if you boost your testosterone or HGH level, what about all the other levels? What about your thyroid level, and what about every other hormone working in your body? Now you're going to be out of balance with that. What's that going to do to the whole system?
Yeah.
We really have no idea. So unfortunately, we're not very exciting about that topic. We're both
Yeah.
pretty conservative. As you can probably tell, we're not taking a lot of HGH. If
Do you know your T
see
level? I don't know.
Yeah, exactly.
We'll check it. We'll tell you later.
Right. Give us 5 years, then
Yeah.
we'll start. We'll be ready. But so I think we'll conclude with that. In summary, basically, we talked about the different stem cell potentials, and from the bone marrow, from the fat cells, which we didn't really get into. I'll get somebody else who does a lot of fat cells, and we'll see what they have to say. The umbilical cord, the amniotic fluid, which Casey does do, which has some ability to stimulate the cells in the human body potentially, and sounds like it's pretty safe overall, similar to a blood transfusion potentially as far as risks go. PRP is the number one thing that he's doing because, one, you can get it from blood, spin it down, relatively affordable for most people, and safe. I haven't heard really of any downside to PRP, and how's that actually sound? So I guess our debate wasn't too stimulating because you're actually a pretty reasonable
Yeah,
guy. Aren't you injecting anybody's eyes or
Yeah.
earlobes or anything weird? So I hope that's been helpful. And if we can help out in any way, I put our office numbers in the link, and especially for biologic injections, feel free to call Casey, and feel free to, if you have any comments, put them at the bottom of this thing and we'll respond to it. And I hope that's been helpful in some way, and hope you guys get to enjoy your Thursday night and Memorial Day weekend. Thanks for coming, Casey.
Yeah, thank you for having me. Yeah.
Yeah.
Go Rams.
That's right.